So let's start by talking about pathophysiology of morbid obesity or even obesity. As you can see here in the table, obesity is a multi-system disease and can affect pretty much every organ system in your body, respiratory, cardiovascular, etc. And we're going to talk more in more details as we go forward in the slides. So let's start by respiratory system. Fat accumulation in the thorax and abdomen decreases the chest wall and lung compliance. Decreased lung compliance is kind of explained by the increased pulmonary blood volume that's related to an overall increase in blood volume, right? Increased elastic resistance and decreased compliance of the chest wall are even more reduced when the patient is supine. So they end up having shallow, rapid breathing, increased workup breathing, and limited maximal ventilatory capacity. That's why we like them to be sitting up. So respiratory muscle efficiency is below normal in the obese patients. Decreased pulmonary compliance leads to decreased functional residual capacity, vital capacity, and lung capacity. Reduction in the FRC is primarily from reduced expiratory reserve volume, but the relationship between the FRC and closing capacity, the volume, which is the volume at which small airways begin to close, is adversely affected. Decreasing FRC and expiratory reserve volume are the most commonly reported abnormalities of the PFTs in obese patients. Residual volume and closing capacity are unchanged, so keep that in mind. That's commonly tested. Reduced FRC from the decreasing the expiratory reserve volume can result in lung volumes below closing capacity in the course of normal tidal ventilation. So you get small airway closure, ventilation perfusion mismatch, right to left shunting, and you get arterial hypoxemia. So anesthesia and supine position worsens this situation. So you get even up to 50% reduction in FRC in the obese anesthetized patient compared with 20% in the non-obese patient. Forced expiratory volume in 1 second, the FE1, and forced vital capacity are usually within normal limits. Expiratory reserve volume is the most sensitive indicator of the effect of obesity on the pulmonary function. Obesity increases oxygen consumption and carbon dioxide production, even at rest. That makes sense because they have more mass. This is because of the metabolic activity of the excess fat in the increased workload of supporting tissue. The body attempts to meet these metabolic demands by increasing both the cardiac output and the alveolar ventilation. Basal metabolic activity is usually within normal limits, though, in relationship to the body surface area and normal capnia. It's usually maintained by increasing minute ventilation. So this requires increased oxygen consumption because most obese patients retain their normal response to hypoxemia and hypercapnia. Arterial oxygen tension in morbidly obese patients' breathing room air is lower than the predicted for the similarly aged non-obese patients in both sitting and supine positions. Chronic hypoxemia may lead to polycythemia, pulmonary hypertension, and chlorpulmonality. Obese patients often suffer from sleep apnea characterized by periodic, partial, or complete obstruction of the upper airway during sleep. In obese patients, OSA is more likely to result from airway obstruction produced by excess soft tissue, but centrally mediated form of sleep apnea can also occur. Physiologic abnormalities resulting from OSA include hypoxemia, hypercarbia, pulmonary hypertension, systemic vasoconstriction, and secondary polycythemia from recurrent hypoxemia. These result in an increased risk of ischemic heart disease and cerebrovascular disease. Right ventricular failure can occur from hypoxic pulmonary vasoconstriction. Respiratory acidosis is usually limited only to periods of sleep, and the gold standard diagnostic test for OSA is overnight polysomnography. The inconvenience, time, and expense of the test leads to an unknown fraction of obese patients with suspicions but no formal diagnosis of OSA. Suggestive signs to look for during the pre-op visit includes witnessed episode of sleep apnea, BMI of more than 35, neck circumference of more than 16 inches or 40 centimeter. And for guys, you can ask them, what is your neck color size when you buy a shirt? And if they say it's 46, that's a problem. Hyperinsulinemia, elevated glycosylated hemoglobin, symptoms of snoring, frequent arousal during sleep and daytime sleepiness, impaired concentration, memory problems, and morning headaches are all common but not predictive. A thorough pre-op eval for possible OSA recommended long enough before elective surgery to allow better preparation and management, but that's not always possible. So pre-op initiation of CPAP, especially in severe OSA cases, should be considered. Patients with confirmed or suspected OSA are very high risk of presenting with difficult airway, more importantly, difficult mask, pulmonary complication, and should be managed accordingly. The obesity hypoventilation syndrome, OHS, or the Pickwickian syndrome may result from long-term OSA that is improperly managed and is seen in 5 to 10% of the morbidly obese patient. That's 5 to 10%. That's a pretty high chance. The OHS is a combination of obesity and chronic hyperventilation that ultimately results in pulmonary hypertension and cor-pulmonale. The presence of both obesity is defined by BMI of more than 30 and awake arterial hypercapnia with CO2 of more than 45. In the absence of any other causes for hypoventilation supports this diagnosis. Prolonged OSA also alters the control of breathing, leading to CNS-mediated apneic events and the increasing reliance on hypoxic drive for ventilation. The main ventilatory impairment of OHS is alveolar hypoventilation, independent of the increasing lung disease. Other characteristics of OHS includes daytime hypersomnolence, hypercapnia, hypoxia, polycythemia, and right ventricular failure can eventually ensue in these patients. They also have an increased sensitivity to respiratory depressant effects of your general anesthetics, your opioids, and benzodiazepines. So let's go to the cardiovascular system now. Total blood volume is increased in the obese individuals, but on a volume to weight basis, it's less than in the non-obese individual. So 50 ml per kilogram for blood volume compared to 70 ml per kilogram in a non-obese patient. Most of this extra volume is distributed in the adipose tissue. Renal and splanchnic blood flow are typically increased. Cardiac output increases with increasing weight as much as 20 to 30 ml per kilogram of excess body fat because of the ventricular dilation and increase in stroke volume. So the resulting increase in left ventricular stress, wall stress, leads to hypertrophy, reduced compliance, and impairment of left ventricular filling, so diastolic dysfunction. And you get elevated left ventricular diastolic pressure and pulmonary edema. When left ventricular wall thickening fails to keep pace with dilation, systolic function, really obesity, cardiomyopathy, and eventual biventricular failure can happen. Obesity accelerates atherosclerotic disease. Symptoms like angina or exertional dyspnea occur only occasionally because many morbidly obese patients often have very limited mobility and they don't move. They appear asymptomatic even when they have significant cardiovascular disease. Blood flow to fat is about 2 to 3 ml per 100 gram of tissue. An excess of fat requires an increase in cardiac output to parallel an increase in oxygen consumption. This leads to a systemic arteriovenous oxygen difference that remains normal or slightly above normal. Intraventricular failure may occur from rapid IV fluid administration, indicating left ventricular diastolic dysfunction. The negative inotropism of the anesthetic agents or pulmonary hypertension precipitated by hypoxia or hypercapnia can definitely occur. Cardiac dysrhythmia may be precipitated by fatty infiltration of the conducting system. hypoxia, hypercapnia, electrolyte imbalance, coronary artery disease, increased circulating catecholamine, sleep apnea, and myocardial hypertrophy. Frequent ECG findings seen in the obese patients include low QRS voltage, multiple criteria for LV hypertrophy, and left atrial enlargement. Also, T-wave flattening in the inferior and lateral leads. Also, there is a leftward shift of the P-wave QRS complex and T-wave axes, lengthening of the corrected QT interval and prolongation of the QT interval. Substantial weight reduction reverses many of these ECG abnormalities in a pretty quick period of time. Cardiac output rises faster in response to exercise in the morbidly obese and is often associated with a rise in left ventricular end-diastolic pressure and pulmonary capillary wedge pressure. Similar changes occur during the peri-op period, which should prompt a low threshold for performing detailed cardiac investigation. Many obese patients have mild to moderate hypertension with a 3 to 4 millimeter increase in systolic and about 2 millimeter increase in diastolic arterial pressure for every 10 kilogram of weight gained. Normotensive obese patients have reduced systemic vascular resistance, which rises with the onset of hypertension. Their expanded blood volume causes an increase in cardiac output with a lower calculated SVR for the same level of arterial blood pressure. The renin-angiotensin system plays a major role in the hypertension of the obese by increasing circulating level of angiotensinogen, aldosterone, and angiotensin-converting enzymes. As little as 5% reduction in the body weight leads to a significant reduction in renin-angiotensin activity in both plasma and adipose tissue, contributing to a reduction in blood pressure. Obese patients have a normal to increased level of sympathetic nervous system activity, which predisposes to insulin resistance, dyslipidemia, and hypertension. The obesity-induced comorbidities are therefore responsible for increased cardiovascular risk in the obese patients. Insulin resistance enhances the pressor activity of the norepinephrine and angiotensin II. Hyperinsulinemia further activates the sympathetic nervous system, causing sodium retention and contributes to obesity-induced hypertension. Hypertension causes concentric hypertrophy of the ventricles in normal weight individuals, but causes eccentric dilation in the obese individuals. It's associated with increased preload and stroke work. The combination of obesity and hypertension causes left ventricular wall thickening and a larger heart volume. So there is increased likelihood of cardiac failure. Obese patients are also prone to cardiovascular disease because of adipose tissue release a large number of bioactive mediators. They can result in abnormal lipid, insulin resistance, inflammations, and coagulopathies. Obese patients have higher levels of fibrinogen, which is a marker for inflammatory process for atherosclerosis, factor 7, factor 8, von Willebrand factor, and plasminogen activator inhibitor 1, or PI1. Increased levels of fibrinogen, factor 7 and 8, and hyperfibrinolysis are associated with hypercoagulability. High factor 8 levels are associated with increased cardiovascular mortality. Increased fasting triglycerides levels correlate with increased factor 7, and postprandial lipidemia causes activation of factor 7. Endothelial dysfunction induced by insulin increases von Willebrand factor and factor 8 levels, predisposing to fibrin formation. Increased secretion of PI1 inhibits the fibrinolytic system and is associated with visceral obesity. Gastric volume and acidity are increased, hepatic function is altered, and direct metabolism is adversely affected by obesity. Many fasting morbidly obese patients who present for any elective surgery have gastric volumes of definitely more than 25 ml and pH of less than 2.5. Delayed gastric emptying occurs because of increased abdominal mass that causes antral distension, gastrin release, and decreasing pH with parietal cell secretions. Abdominal obesity increases the Intragastric pressure increases the frequency of transient lower esophageal sphincter and or hiatal hernia formation. An increase of more than 3.5 kilogram per square meter in BMI is associated with a 2.7-fold increase in risk of developing new reflux syndrome. An increased incidence of hiatal hernia and gastroesophageal reflux further increases aspiration risk, as you know. Gastric emptying is faster with high energy content intakes such as fat emulsions, but because of larger gastric volume, which can be up to 75% larger, the residual volume is increased. The combination of hiatal hernia and GERD with delayed gastric emptying coupled with increased intra-abdominal pressure and high volume with low pH of gastric content puts these patients at a pretty high risk for severe pneumonitis should aspiration occur. Unpremedicated, non-diabetic, fasting, obese surgical patients who are free from significant GERD are unlikely to have high volumes, though, with low pH gastric content after routine pre-op fasting. They should follow the same fasting guideline as non-obese patients and be allowed to drink clear liquids even up to 2 hours before surgery. Weight loss significantly improves this gastroesophageal reflux symptomatology. Peculiar morphologic and biochemical abnormalities of the liver are associated with obesity and include fatty infiltration, inflammation, like NASH, focal necrosis, and even cirrhosis. Fatty infiltration reflects the duration rather than the degree of obesity. Histologic and liver function test abnormalities are relatively common, but clearly usually is not reduced. Abnormal liver function tests are seen in up to 1/3 of the obese patients who have no evidence of concomitant liver disease. The most common abnormality is an increased ALT. Despite these histologic and enzymatic changes, no clear correlation exists between liver function abnormalities and the capacity of liver to metabolize drugs in these patients. Morbidly obese patients who have undergone intestinal bypass surgery have a particularly high prevalence of hepatic dysfunction and cholelithiasis, and this is common in general obese population due to abnormal cholesterol metabolism. The high prevalence of NASH and cirrhosis necessitates careful assessment for pre-existing liver disease in these patients that are scheduled for any surgery. Features suggestive of NASH include hepatomegaly, elevated liver enzymes, and abnormal liver histology, so steatosis, steatohepatitis, fibrosis, and cirrhosis. Impaired glucose tolerance in the morbidly obese patient is reflected by a high prevalence of type 2 diabetes as a result of resistance of peripheral adipose tissue to insulin. Many obese patients have an abnormal glucose tolerance test, and the relative risk of developing diabetes is increased by 25% for every 1 kilogram per square meter increase in BMI above 22. So 25% for every single increase in BMI over 22. Hyperglycemia, insulin resistance, and diabetes predispose obese patients to wound infection and increased risk of MI. Exogenous insulin may be required perioperatively, even in obese patients with type 2 diabetes, to oppose the catabolic response to surgery, so not necessarily just sugar. In addition to these concerns, subclinical hypothyroidism can occur in about 25% of all morbidly obese patients. Thyroid-stimulating hormone levels are frequently elevated, suggesting that the possibility of obesity leads to a state of thyroid hormone resistance in peripheral tissue. Hypothyroidism may be associated with the hypoglycemia, hyponatremia, and impaired hepatic drug metabolism. Obesity is associated with glomerular hyperfiltration, which is evidenced by increase in renal blood flow and increase in glomerular filtration rate. Excessive weight gain increases renal tubular reabsorption and impairs natriuresis through activation of the sympathetic and renin-angiotensin system, as well as physical compression of the kidneys themselves. With prolonged obesity, there may be a loss of nephron function, which further impairment of natriuresis, and further increases in in arterial pressure. Obesity-related glomerular hyperinfiltration decreases after weight loss, which decreases the incidence of overt glomerulopathy. Say that 3 times. The metabolic syndrome, sometimes referred to as syndrome X, not anymore really, and insulin resistance syndrome, is a cluster of metabolic abnormalities associated with an increased risk of diabetes and cardiovascular events. People with this syndrome have up to 5-fold greater risk of developing type 2 diabetes, if not already present, and are also twice as likely to die from MI or stroke compared to those without the syndrome. There are several diagnostic guidelines for metabolic syndrome, and the most widely used one is from the 2004 National Cholesterol Education Program and the American Heart Association, which defines metabolic syndrome with 3 out of the following 5 conditions. So central obesity with waist circumference of more than 102 centimeters or 40 inches in males or 35 inches in females. Dyslipidemia with triglyceride of more than 150 and HDL of 40 in males or 50 in females. Hypertension and elevated fasting glucose 100 or use of medication for hyperglycemia. Weight loss and lifestyle changes like following a Mediterranean diet with high intake of fruits, vegetables, and fibers improve the metabolic syndrome features.